All right. So, ladies and gentlemen, welcome back to our Equality International Ground Rounds. It's the fifth segment. After 1 year, we started back, and I'm very pleased and delighted to have the first guest speaker today, which is Professor David Kennedy from US. Good morning, Professor.
Good morning. Good morning.
So, the talk today is management of recurrent chronic rhinosinusitis. I think that Professor Kennedy do not need any introduction. So if anyone will join and go for questions, please, I do remind all the attendees to type your question. We'll proceed and we'll ask those questions at the end of Professor Kennedy at the end of his talk. So if you would like to share your screen, please.
So, good morning. So what I'm really going to talk about is the sort of difficult to treat patient with chronic sinusitis, not just the patient who has occasional recurrent chronic sinusitis, but rather the patient whose disease comes back and is resistant to medical therapy, or maybe resistant or has been resistant to medical therapy. So that's the sort of background of where I'm going to go. These are my disclosures. I don't think there's anything particularly relevant, although I will talk a little bit about image guidance with Viagon. When you're faced with a patient with chronic sinusitis, even a patient who's had prior surgery, I think one of the things to, wait a minute, this flipped my screen. Let me go back. When they started the recording, it just flipped the screen a little. Okay, so one of the really important things is whether or not the patient's symptoms are actually coming from the chronic sinusitis. So these are some of the things that I think about when I'm first faced with the patient. And the other thing to think about is how much of the patient's symptoms are due to environmental factors, how much are due to general host factors, and how much are due to the local host factors, the sort of things that would actually be helped by surgery. And those are important things to consider, because we do know that there are a lot of general diseases, autoimmune problems and immunologic issues that can predispose towards chronic sinusitis, and they may or may not be helped by surgical or surgical intervention. Lastly, we want to know, is the patient complying with their medical therapy if they've been on it in the past? That's not always the case. And I'll talk a little bit more about that later. So, so one of the important things to recognize is that classic headache is not a good sign of chronic sinusitis, nor is severe pain. Those things may happen with acute sinusitis, particularly a first episode of acute sinusitis, but they are rare with chronic sinus disease. So very rare. So if you've got those things, you need to start thinking about something else. So this is a patient, just an example of a patient who was sent to me years ago. And he'd had, I think, or she had had 4 surgeries. And you can see here that the patient has a lot of neoosteogenesis. There's still some uncinate process. The turbinates have been taken. And the patient's primary complaint is headaches. So what I actually did was to get the CT scan before the first of their 4 surgeries that they'd had done elsewhere. And this is the CT scan. So the patient actually never really had chronic sinusitis or the cause for headaches, but now they've got chronic sinusitis after all the surgeries that were in. But yes, it's not the cause of the headaches. So now my screen has. So one of the first things that I do with my patients, even before considering a revision or even a primary surgery, is to do high-dose, high-volume steroid nasal irrigations. And we have found that that has significantly cut down on the need for surgery, and also, of course, is critical in the postoperative period. It seems to be very safe, although, of course, it is not in the US FDA approved. But all the studies that have been done, it seems to be safer than inhaled steroids for asthma. So what we've been able to demonstrate is that it actually cuts down the need for surgical intervention. And I usually give my patients that come to see me 4 to 6 weeks of steroid nasal irrigations before we actually make a decision about surgery. And in many cases, before we actually do our imaging, and then see what it looks like at that point in time. And what we found is that a significant number of patients decide, I'm doing pretty well, and they know they're going to have to do the irrigations in the early post-op period anyway, so they elect not to have surgery. Topical steroids do all the things that we want to do in chronic sinusitis, and I think that that's important to recognize. So one of the things that often comes up is, what's the definition of appropriate or maximal medical therapy? And there's not a simple answer for that, because it varies to some extent on what sort of disease the patient has. So if the patient has eosinophilic disease, typically associated with polyps in the West, then we know that steroids are going to be very effective. They're also effective in neutrophilic disease, but not as effective. And then we might want to consider either antibiotics, topical or systemic. And if we really want to get more precise in terms of what the issues are with the patient, then we can do cytokine analysis. So when I see a patient with recalcitrant, recurrent, persistent disease, these are some of the things that I think that I may want to do. And of course, I don't do them on every patient, but I am likely to at least do an endoscopic culture unless it's clearly eosinophilic polypoid disease. But we need to think about these things as some of the both environmental and general host factors that may be leading towards chronic sinusitis. So at least put these in the back of your mind as possible tests that in certain cases you may want to do. So in a patient who's had prior surgery and now they're still having issues despite their steroid nasal irrigations, the next step is obviously imaging. And what we focus on there is how many bony partitions are still present. Because if the bony partitions have really been very well removed, then that patient may just be a candidate for medical therapy and may not require a revision surgical procedure. So in a situation like this, you might consider just medical therapy, whereas in a situation like this, where the patient's had prior surgery, there's still a whole lot of bony partitions present, then I think that we're going to want to at least make sure that the patient has a complete surgical procedure before we decide that we can't, that we are just going to do medical therapy alone. So this patient obviously needs surgical intervention, take down those residual bony partitions, and I would have a low threshold for taking that patient to surgery. So in the patient who's had prior surgery, what do we look for on nasal endoscopy? Well, these are the things that we want to look for and try to identify when we examine that patient endoscopically. We want to try to identify the medial orbital wall. We want to see what partitions are present. We want to see if we can see the skull base. We want to make sure the sphenoid sinus was opened Can we identify the frontal sinus pathway? These sorts of things are what we look for on the actual nasal endoscopy. Of course, we want to know if there are any potential areas of dehiscence as well. Looking at the CT scan, we go through our standard conceptualization of things that we need to look for: the extent of prior surgery, obviously the roof and the medial orbital wall, the vertical height of the posterior ethmoid, really very important. And then, the sphenoid sinus and the frontal recess. So here's a situation where we have a very narrow vertical posterior ethmoid, as you can see. And what we do is we just sort of compare the height of the maxillary sinus to the height of the posterior ethmoid. And that gives us an idea of how low the skull base is and what we're going to find at surgery. The bottom line is, if you see a low skull base, when you get in surgically, it's always going to be lower than you thought it was going to be. And here's the situation where the surgeon actually didn't recognize that on the other side, and you can see the patient has an intracranial entry. So this is another case where someone didn't recognize a low skull base posteriorly. And again, we see the difference in height between the maxillary sinus and the posterior ethmoid. And this is the result. The patient has a bilateral skull base defect following the surgery. The patient was comatose, transferred into us. And actually, I never got the chance to close the defect because the patient was so unstable that they couldn't even take the patient to the operating room, and the respirator had to be turned off. It was very sad. So looking at that vertical height of the posterior ethmoid is critically important. So if we do end up doing surgery, then it's really important that we do a very complete surgical procedure. And that means having the appropriate instrumentation to get up and really open up that frontal sinus very widely, to make sure that all of the bony partitions are taken down. If the bone's really thick, you might even have to use a diamond burr. We do have to do that occasionally to get some of those bony partitions down, but we still want to try to preserve the mucosa on the skull base and on the medial orbital wall. And then we need to be prepared to follow that patient post-operatively. So here I am waiting for the surgery to start, and you can see what I'm doing is I'm scrolling through the image guidance images so that I can conceptualize that anatomy before we actually start the case, particularly the frontal sinus drainage pathway. Obviously, I look at this before, but I look at it again in the OR, and I really try to make sure that I understand every bit of that anatomy, and I've got it conceptualized before we start. And if you do that, then image guidance during the surgery is not so important. You don't have to have image guidance to do this. You can look at the films very carefully, but it certainly helps because you can do it dynamically, or at least with that software. So what's changed in terms of our surgical approach? Well, obviously we used to do this under local years ago. We don't do that anymore. If I compare to my residency, anesthesia has gotten 60 times safer than it was during my residency in the 1970s. So it's a huge change. We obviously do it under general, with hypotensive general anesthesia. We've changed the way we do our injection sites, and in actual fact, in most cases, you don't need to do injection sites. You can actually just use topical epinephrine as 1 to 1,000 as an alternative to doing injections in many cases. So this, on the left, you see what we did back in 1985 with multiple injections. When we were doing injections, this is 1% xylocaine with 1 to 100,000 epinephrine. Now I just do one intranasal injection, which you see here, right in the crotch, and you see it blanch both on the lateral nasal wall and on the middle turbinate. And that first injection is so important because once you've made one hole, what we saw is if you make a second one, it just leaks out of the first hole. So that first injection needs to be very precise, and then you can get that wide blanching in both areas. If I'm going back into the posterior ethmoid or into the sphenoid, I like to do a transoral injection through the greater palatine frame, and you bend the needle at 2.5 centimeters, and you go up through the greater palatine frame and feeling for it. Aspirate frequently during the injection, multiple aspirations. You don't want to get intravascular because visual loss has been recorded, and we then slowly inject in that area. During the surgery, the key is to really identify the medial orbital wall very carefully, feeling behind the bony partitions until you have first the medial orbital wall. Now, as you think about landmarks, particularly in the revision surgery case, you can't rely on the middle turbinate, but the medial orbital wall is critically important. So we want to identify that medial orbital wall and then the skull base. So we feel behind the bony partitions, we through cut them until we can see those particular landmarks. And people sort of sometimes get afraid by the medial orbital wall. Well, it's exactly like looking for the tegment plate or the sinus plate during a mastoidectomy. That's your landmark that you want to follow, and then you want to be able to identify the skull base. So if the bone's thick, you can't always through cut it. What I do in that situation is fracture it with a Blakesley forceps, and then use the microdebrider to take down the underlying tissue. So we used to be taught that what you did to know if you're on the medial orbit was to press on the eye. That's a terrible thing to do. If you can see something move when you press on the eye, you've gone too far already. You've at least taken off the bone, and the chances are you've already got orbital fat. So what we do is called the laminar push test, and this is what you see here. When you get it skeletonized, if you push with an instrument, it moves as a unit like you see here. And then you know you're on the medial orbit, and you sort of take those bony partitions down until you get to that point, and then you do that laminar push test. And what we see time and time again, you can see it here moving as a unit. This patient probably does have some bony dehiscence there. Here's another one. I think in this case, you'll see that we're pressing on the orbit, nothing happens, but with the instrument test, you'll actually start to see it move. And this becomes more important. These are all revision cases. And so here's the lamina. It's still got the mucosa over it, but I've gone down to the lamina. And you can see nothing happens when my resident pushes on the globe. You don't see anything move. But with the instrument test, you can see it sort of move as a unit. And that's really an important concept. So the old orbital thing should go out of the window. So I want to remove all of the bony partitions, identify, of course, preoperatively where the anterior ethmoidal artery is, and then preserve it. And then what we see here is the situation. We've got a supraorbital ethmoid, a supraorbital ethmoid. There's the frontal. Here is the anterior ethmoidal neurovascular bundle running, in this case, just below the skull base. From the standpoint of the maxillary sinus, the key is to make sure that this anterior portion is really opened. And you may say that sounds easy, but the uncinate process, particularly in revision case, can be quite thick over this area and difficult to remove. So in order to be sure that you've got this area open, which is absolutely critical in terms of mucociliary clearance, what I do is to take the backbiter, open it, and then rotate it anti-clockwise to flip that piece of bone off. Of course, the nasolacrimal duct is right in front, but we want to use a 45 or a 70-degree scope to really make sure we get this anterior portion open it is the critical area in terms of an antrostomy. So let's just take a look at a video of a patient with some polyps who has not had prior surgery, but does have a pretty low posterior skull base. And so you can see fairly low posterior skull base. I'm doing my injection here, just like we showed. I can't see the medial orbital wall here yet, so I'm just putting a little injection into the polyps before I start. I have put in some topical cocaine, actually. Now I'm doing my lateral nasal wall injection. But what I like to do, my first landmark, for most people, it's the maxillary sinus. Mine is actually the medial orbital wall. So my first landmark, and I have no objection to opening the maxillary sinus early. I just don't do it. This is one of those cases where the bone was thick and I was fracturing it with a Blakesley forceps. And you can see I could through cut some, but not everything. And here I'm just doing my anterior ethmoid dissection. So let's just take off the buller a little bit. We're going to have to really identify that medial orbital wall as our first landmark. Very thick bone here, in addition to the low skull base. And I'm starting, now I can see my medial orbital wall. I don't know if you could see it there, but I had it skeletonized. We're just going ahead and going posteriorly within the ethmoid. And now I've got the posterior ethmoid open, and you can see that low skull base. Now I'm going to open up the sphenoid. The way to do the sphenoid is to identify the superior meatus, and that's what I'm doing here. And then I'm going to take off the inferior portion, the superior turbinate. That's going to lead me right back to the ostium, which I'm going to identify with a probe. If you've got an image guidance probe, you can use that. Identify the sphenoid ostium, as you see here. Then I want to take this all the way up to skull base and to medial orbital wall to make sure that it is as wide as it could potentially be. And it also provides me with an additional verification of the position of the skull base and the position of the medial orbital wall. So now we're coming forwards, and we're going to go up into the area of the frontal recess. We've identified medial orbital wall. We've identified skull base posteriorly. Once I've got that skull base identified, I know that I can take anything beneath that away without any risk. Just have to stay a little bit lateral, make sure that I don't get into where the skull base slopes down into the middle turbinate. So now I'm going to open up the maxillary sinus. As I said, I have no problem doing this earlier. But I usually do it last, because to me, the medial orbital wall is the important landmark. And what I want to show here is just taking off that piece of unsnate. You can see it's very thick, and you can see how I'm flipping it out there. And if I didn't do that, then I think the patient would have continued to have problems, despite the fact that the maxillary sinus was already opened a little bit more posteriorly. So now you can see the skull base, the medial orbital wall. That's the maxillary sinus again, but there's the skull base, medial orbital wall, and up into the frontal sinus. So one of the questions that often comes up is whether to open up the frontal sinus, and if so, what do you actually do? And I think it depends on a whole lot of different factors that we need to consider here. There are a lot of different options. Obviously, if you're not used to opening the frontal sinus, identifying it with a balloon can be helpful. Also, using an image guidance probe can be very helpful. What I think we do know now is that draft 3 procedures actually work very well. I really like this malleable probe that I can bend and put up into the frontal sinus, because if you bang up there with a suction, trying to find the ostium, if you don't know it exactly, then you start causing significant trauma. But with one of these very fine malleable probes, you can slide it up into the frontal sinus very nicely, even when a suction won't go up there. And here's a video just showing one where a curved suction won't go up into the frontal. But now I'm sliding the probe in, and you can see it on the image guidance picture, how it's nicely gone up into the frontal sinus. And we see that time and time again. And it enables you to then feel confident that you're in the frontal sinus and that you know exactly where it is. So here's another one with the probe going up very nicely. But you'll see that a suction won't pass. It's too narrow. So I really love this this fine malleable probe in terms of getting up there. So what else has changed? Well, I think one thing is that in patients who have persistent frontal sinus disease, despite good surgery, we do know that a draft-free works and holds up long-term, something which we have slowly seen over time, and it allows irrigation to get up into the frontal sinus much better to resolve that inflammation. So what we've learned is, firstly, don't go back to the olfactory fillet. That is a bit too late because that first olfactory fillet can have a little dura around it. We want to go from lateral to medial and do the drill out, coming all the way forwards to the subcutaneous area and all the way lateral until we're right on the periorbital, being very careful in that drilling. Two things that I think has changed. The biggest thing that's changed for me, I used to use free grafts for the draft-free, or I used to sometimes use a septal mucosal graft. And Otori in Tokyo recommended the use of this slap graft that you see over here. And that really has changed, I think, the way this heals dramatically. So one thing that's changed is having a 30,000 RPM curved burr. That really helps me a lot. I think it's less trauma than a straight burr, and it's much faster than the old curved burrs. Putting this slap flap up into the frontal to cover the bone has really dramatically improved the healing from my standpoint. And what I do to hold it in place is I just put in a Propel stent, a steroid-eluting stent that just holds the flap in place and makes sure that the bone is covered. And for us, that really, I think, has improved the healing dramatically and made it much less variable. So once we've done the surgery, obviously, we want to follow those patients and make sure that the cavity goes back to normal. We have to remember that the surgery is just adjunctive to our medical therapy. Surgery itself rarely cures chronic sinusitis. All of these patients, particularly the recalcitrant patients, have persistent inflammation after the surgery, and that has to be brought under control. And of course, the biggest way of doing that now is with the high volume, high dose steroid nasal irrigations. But of course, oral steroids in the early postoperative period and other adjunctive therapies need to be considered when that is not sufficient to resolve all of the inflammation. Lastly, I spend an awful lot of time in terms of patient education. And the reason is because we know that compliance is very poor. I'm a chronic sinusitis sufferer. I'm not great at doing my steroid nasal irrigations. And the literature really bears this out, even in terms of taking pills after a heart attack. The literature shows patients are not compliant. And so spending a lot of time in patient education and improving compliance, I think, is really important. Patients who continue to do steroid nasal irrigations on a regular basis, in general, do very well. But it's tough to do because, you know, they feel good, And what we see endoscopically is changes long before the patients become symptomatic. And I think that this is an area where in the future, we will be probably using biologics. And in fact, we do already to some extent in patients that we see persistent inflammation, even if they're pretty asymptomatic. If we see persistent inflammation, then I have them, we work with John Bosso in our clinic, and we have them evaluated for the possibility of whether or not they might need something more. So these are some of the things that we think about. Our goal is not just to resolve their symptoms. That's easy. Patients feel better right after surgery if you do it right. But what we want to do is to really get them to go back to being endoscopically normal. And that takes a significant amount of work and time. If we don't do that, then they may recur down the road. So one other thing that's come in the US that we found very helpful is the Optinose Xhance device. I don't know if you have that in Italy or not, but what it's been shown is that this really gives good deposition of a high-dose fluticasone throughout the nose and even back to the eustachian tube area. And it gets up into the frontal sinus better, I think, than the irrigations do. So we've been pleased with that. There are insurance and cost and coverage issues that we have to work out. But we do use that. So we follow these patients endoscopically. We do post-operative care. We evaluate the medical therapy based on what we see endoscopically, not by the patient's symptoms. Why do I say that? Well, if I have an AERD patient with total nasal obstruction, and I see them 1 week post-op, and we look at their snot scores, they are usually 0 across the board. And yet we look in there and they have massive diffuse inflammation. They just feel so much better that they've got rid of their total nasal obstruction. So the subjective scores only tell a little bit of what really is going on. So we do our regular post-operative care on these patients. We follow them fairly carefully. And do procedures in the office as we need to during the healing period. And how much we have to do this depends a lot on the patient. It depends on the inflammation that's present. Obviously, for a first surgery, minimal disease, it's probably very minimal. But in these patients that I'm talking about, the patients that I typically see, the patients that have failed prior surgeries, then it becomes extremely important to both follow them endoscopically and to make sure that the inflammation resolves. So I'm going to stop at this point. I'm going to encourage everyone to come to the Academy meeting next year, which is actually in Philadelphia. And Penn, we are going to be putting on a whole number of different courses immediately prior to the course. So I'm going to invite everyone to come to one or more of those courses, depending on someone's area of interest. So, all right, I'm going to stop at this point, and I'd be happy to answer any questions.
Thank you very much, Professor Kennedy, for the brilliant presentation. It's a master in talking here. So if anyone joined recently or in the last few minutes, Professor Kennedy explained us the news or actually what's his thought on the management of recurrent chronic rhinosinusitis. We have pretty amazing number of questions. I will try to go through all of them one by one. Before doing this, I think that nowadays, after 2 years of pandemic, we can understand the importance of courses, dissection courses, teaching courses. The things that we were used to do nowadays are gold. And I suggest all the residents to keep up to date with those courses because it's mandatory prior to your own surgical theater position. So after this, I would directly go with the questions. So the first questions from the audience is, what is the role of nasal cytology in the diagnosis and the treatment of chronic rhinosinusitis with or without nasal polyps?
So I think it's helpful. It's actually not something that we do that frequently. We actually usually treat the patients up front the same way, but then when we look at the pathology, we get a much better idea of the quantification of the number of eosinophils present. So we do know that for whatever reason, neutrophilic disease does respond to topical steroids. So I don't usually do cytology up front, but when we do the pathology on the specimen, then we want a quantification of the eosinophils present as much as possible, because that will help to guide our long-term management.
The second question from Egypt is, do you prefer any medical management before radiology to rule out retained secretion crossing and such things?
So give me that one again, if you would. Sorry, do it.
Sure. So the question is, do you prefer any medical management before radiology to rule out retained secretions, crusting, and such things?
Yes, so we will usually treat the patient. So most of the patients that I see have already been on steroid nasal sprays on and off for a long period of time. A lot of them, 85% of them, have had prior surgery. So the first thing that I will do, if they haven't done it already, is to put them on high-dose, high-volume steroid nasal washers. And I will do that for 4 to 6 weeks before I do their imaging, unless there's any question about the diagnosis at the beginning, in which case we'll image them up front. Or if we think there might be a complication present, we'll obviously do the imaging up front. Or if we thought it might be a tumor. But if not, then we treat them medically for 4 to 6 weeks before we actually do the imaging.
The next question is from Russia. What is your opinion in regards to biologics and surgery? There will be still place for surgery?
I don't think so. So we participated in an NIH meeting combined with allergists and otolaryngologists. And I think that everyone there was of the opinion that the biologics should be maintained for patients who have either failed surgery or who do not want or cannot have surgical intervention. The problem is the cost. And, you know, the question about what the long-term side effects may or may not be from a lifetime of biologics. But I don't think anyone has to worry that it's going to replace our surgery. Although there are some allergists in the US who are doing it prior to surgery, that is not what the experts actually recommend, even the expert allergists.
Next from France. What would you do if the patient's presenting edema 2 weeks after surgery?
So they will have, so the edema is actually maximal at about 2 or 3 weeks after surgery. And what I typically will do is in the early post-op period, unless there's a contraindication, I will put them on some oral steroids to keep that edema down. I worry that if they get very edematous, they're going to, again, retain the mucus, which we know gets contaminated with bacteria and with mold, and may keep that vicious cycle of inflammation going. So what I do is early post-op, in addition to the high-dose, high-volume steroid nasal washers, I will put them on some oral steroids to keep that edema down if there's not a contraindication to oral steroids. Try to keep it down, and of course, suction them out when they come back for their follow-up visits. Again, we do worry that the mucus sitting there in the maxillary sinus or in the frontal is going to get contaminated, and just keep that inflammatory process going a bit.
The next from Belgium. Are you suggesting aspirin desensitization before surgery?
No. So for the AERD patients, the aspirin sensitive patients, we know that the right time to do that is about 4 to 6 weeks after surgery. You want to minimize the polyps present first for two reasons. One is it reduces the chances of the patients having a reaction during the allergy, during the aspirin desensitization, but also it gives the best possible chance. Complete surgery gives the best possible chance for success with the aspirin desensitization. So I have them see our allergist prior, but then we book the aspirin desensitization if they're aspirin sensitive for about 4 to 6 weeks after the surgery. And at that stage, they either have to be off oral steroids or on very minimal oral steroids so that they can go ahead with the desensitization.
Another question from UK. What is the role of allergen testing and immunotherapy?
So it's very important. So we have to think about these environmental issues. We used to think, that if a patient had a concha bullosa and you sort of took the lateral half of that off and it opened up the maxillary sinus, everything was going to be great. But in actual fact, we know what happens then is you open up a whole lot of virgin mucosa to the same environmental factors that probably started this in the first place. And in actual fact, the concha bullosa may be, and we don't know this for sure, but it may be a defensive mechanism to some extent to protect the sinuses. So yes, I want to make sure if there are environmental factors present, I want to get them tested for that early, because that's going to be important for their long-term management. It's not going to resolve the chronic sinusitis that they have, but it is important so that they don't get recurrence later. And so, yes, we do allergy desensitization in those patients.
This question's from Egypt. I probably need to rule out this one because our colleagues is saying, if you have a lamina dehiscency, would you suggest packing the nose?
So this is if you get it during the surgery. No, you would not want to pack the nose. You want to leave the nose open. And in fact, we don't use packing that often, really at all. Even in patients that don't have it. But the risk is once you have a lamina dehiscence, or particularly any fat exposure, you don't want to pack that, because then there's only one way for the blood to go, and that's right into the eye. And we want to make sure that doesn't happen. So if you do get a lamina dehiscence, and certainly any exposed fat, you don't want to pack that nose. In any case, all that I do is to put in a Maricel sponge if I need one at all, and then I take it out within 24 hours. So I leave them pretty much open. Occasionally we will use a Propel stem.
This question is coming from Brazil, and the colleagues is asking, what's the mixture you using when you place cotinoids inside of the nose before surgery?
Yes, so we would use 1 to 1,000 epinephrine. 1 to 1,000, just squeeze them out a little bit so it's not dripping. And we would use 1 to 1,000 epi, or we can use some topical cocaine as well. But epi is probably a little bit safer. So I would not do that on a patient with significant cardiac history, but it does work very well.
Question from Marrakesh. When you starting using steroids after surgery?
So oral steroids, we will start right after surgery. So my my typical sort of post-operative care would be an oral steroid starting right after surgery, and usually 30 or 20 milligrams of prednisone is sufficient just to keep that edema under control during the healing period. I just want to make sure that it doesn't scar off from edema, or we don't get a whole lot of stasis. And then I'll taper it down in the early post-op period. People said, always ask, well, how long's your steroid course? But it all depends upon the endoscopic appearance. So I'll be seeing the patient back at a week, I'll be seeing them back at 2 weeks, and I will be tapering over that time period based upon how it looks endoscopically. The other question is oral antibiotics in the postoperative period. The evidence for that is not good. That said, I do use oral antibiotics in the postoperative period, particularly in the patient with neutrophilic disease or more inflammation present. I think I have to say the evidence is not there. It's one of those things that maybe I shouldn't be doing anymore, but I do use oral antibiotics in the early post-op period.
It's fascinating because last time Witzke Falkens, I invited Witzke for a talk on the updates on EPOS guidelines, and she was actually saying the same. Like the evidence is saying that actually will not work, but then she's using that too, and it's a bad habit that we might having. I don't know, but we need to apply with this for sure.
It needs more studies. It needs more studies. The other thing that I think we need to look at more carefully is the use of topical antibiotics post-surgery. Again, the evidence is not there that topical antibiotics are helpful. That said, we know in other forms of wound healing, if you do it by 16S sequencing, then they really improve wound healing post-op. And it's an area for further study, but we need to do it with 16S sequencing, not just with cultures.
I think that we don't have enough time for other questions. If anyone interested, of course you can. If you agree with this, you can contact Professor Kennedy, and he might be able to respond somehow. Of course, and join in his courses, you will have the chance also to learn something new. Last time, Witzke was telling me the differences of clinicians around Europe of using a SNOT-22. Are you recommending using the SNOT-22 routinely on your patients, or you just would address the usage of a SNOT-22 for the patients with the chronic rhinosinusitis, those ones that are resistant to the medical therapies?
So we do it routinely. All of the patients with nasal sinus complaints get the SNOT-22 in the waiting room. They fill it out, or they fill it out online before the visit, and it goes into our electronic medical record. We scan it in. It's a useful way of following the patients. The problem is that there's too much emphasis on sleep and other sleep is affected, of course, dramatically by chronic sinusitis, but there are so many other factors involved with how well a patient sleeps that you can't really, when you see high scores in the sleep area, you can't say that's due to chronic sinusitis. But yes, I find it very helpful. It gives me a background on the patient, what's bothering them. I use it, but it's important to remember the patient symptoms, although it's important to the patient, that's not what really should be important to us as otolaryngologists. We want to see that inflammation and make sure that it really settles down. And that doesn't correspond well to patient symptom scores.
Thank you very much, Professor Kennedy, for your participation. I really enjoyed. I'm really pleased that I had the chance to invite you in one of our ground rounds. I really hope to see you very, very soon in the US, and if you would like to accept my invitation for the next semester, of course. I really think that events in person will help a lot in the future, in the meantime, I'm taking this few seconds to remind everyone next appointment is October 27 with Aki Psaltis from Adelaide University in Australia. You can check out our previous ground rounds in our YouTube channel. So if you missed Professor Kennedy's talk, you can just go on our YouTube channel and watch it again. Thank you for your time, Professor Kennedy. Stay safe, and I hope to see you very soon. Goodbye.
All right, see you all next at the Academy meeting. Take care. Okay.